Yes, madam. Just I will call Nikhil to share the PPT. So, very good evening and welcome to the third talk of the breast webinar series on biomarker testing in breast carcinoma. And it's my great pleasure and honor to introduce our distinguished speaker today, Dr. Ayushi Sahai, professor at TMH Mumbai. Madam earned her MD in pathology from AIIMS New Delhi in 2007. She received training in autopsy practices from PGA Chandigarh in the same year and also completed her senior residency at AIIMS New Delhi and SMS Medical College, Jaipur. She began her career as a consultant pathologist at Seven Hills Hospital, Mumbai in 2012 and has been with Tata Memorial Hospital since 2014. Currently, she is a professor of pathology at TMH Mumbai. Dr. Sahai's areas of interest include neuro and breast oncopathology and digital pathology. She has presented almost about 31 papers at various international, national, and regional conferences and has received numerous awards, including the Srimati Kunti Devi Mehrotra Award for the Best Published Paper, the Dr. V. Ramalinga Swamy Award for the Best Oral Presentation, and Dr. H.D. Tandon Award for the Best Poster Presentation. She has also won Best Poster at ISNOCON, that is Indian Society of Neuro-Oncology in 2015 and 2018. Additionally, she also received a travel grant for the Best Abstract selected for oral presentation at ISNOCON 2017. Madam has over 120 papers in index journals, 5 book chapters, and more than 30 published abstracts. She is a reviewer for several international and national journals, member of the Breast Disease Management Group, and current secretary of the Neuro-Oncology Disease Management Group at TMH Mumbai. Welcome, Dr. Sahai. We are so grateful to have you with us. Now, it is my great privilege to invite Dr. Sanudev Sadanandan, Assistant Professor in Department of Medical Oncology at Government Medical College, Kozhikode, who will be the moderator for today's session. Sir completed his MBBS from GMC Kozhikode in 2009 and his DNB in radiotherapy from Regional Cancer Center, Thiruvananthapuram. He had a fellowship in radiation oncology from National Cancer Center, Singapore, MSc in bioinformatics, doctorate of National Board in Medical Oncology, and he got his DM from Medical Oncology from SKIMS Srinagar in 2020. He began his career as a radiation oncologist at Baby Memorial Hospital, Kozhikode. He has worked in renowned institutions, including the Malabar Cancer Center, Talasheri, and India Cancer Center and Research Institute. Since 2022, he has been working as an assistant professor in medical oncology at Government Medical College, Kozhikode. His fields of interest include solid tumor oncology and precision oncology. He has about 9 publications in peer-reviewed journals. Over to you, Dr. Sanudev. Dr. Sanudev?
Yeah, yes, madam. So, on the outset, I sincerely thank the IAPM organizing team. Regarding biomarkers in breast cancer, it's very interesting. And previously, we only had all those ER, PR, HER2, and Ki67 for a resected or those who we are planning for neoadjuvant therapy. Nowadays, we are, going into more and more biomarkers even in breast cancers. Nowadays, for metastatic setting, we are routinely doing PDL1 testing. Then for progressive HER2 positive, ERPR positive cancers who are progressing. We are doing PIK3CA to select our further lines of therapy. We can even test for TROP2 for those who are getting benefited out of sacituzumab. Lot of newer agents. And for HER2, we have been refining. Previously, we had only 0. Even we were saying positive or negative, 3+, 2+ with FISH. And sometimes we report 1+ or 0, depending upon the center where we are getting the report. Now we are refining that HER2 negative subsets into proper 0 versus 1+ versus 2+, and whether it is ISH negative or positive, where we have nowadays targeted therapies are available. Like there was a recent trial which is published in Destiny +04. So it is selectively addressing this subset of patients. So now we have refinement in IHC techniques, FISH techniques, and we are using more and more NGS, PCR, SANCAR, and all those techniques. And the germline testing is another important avenue where we are almost every breast cancer. We are testing for germline BRCA1, BRCA2, or an HRR panel. That means an extended panel of testing. And selected indicator approved. So it's becoming more and more complex day by day. We test for metastatic post multiple lines. We send for an NGS to select for therapy where you have entrectinib for NTRK positive. And so many tissue agnostic approval, like when you have a TMB high breast cancer post multiple time, you can, if you have not used immunotherapy, you can use immunotherapy. MSI high subset, you can use immunotherapy. So it has been becoming more and more complex. And breast, as it is a very important disease, which has mortality is high, especially in the stage 4 disease. Survival, all, and when you combine the entire stage 4, your survival is somewhere in the tune of 30% still, when you collect the whole world data. But in certain subset, it has been increased to 5-year survival of around 50-60% also. So a better pathology report than IHCs, FISH, and supplemented by NGS or any other molecular technique, like PCR, Sanger sequencing, and all those things to identify germline or somatic panels will help us to refine our treatment. Rather than offering the same treatment to everyone, we'll be able to identify our target, and target each individual patient can be targeted accordingly. And on the other side, the cost of these agents are very high. When I say sacituzumab govitecan, I have to import it. But the other agent, deruxtecan, is available in India, but it's too costly, 3.5. But over time, all these agents will come down to a lower cost. Maybe 5 or 10 years down the line when the patent expires, we'll get that. So, but if we do all these tests at this point of time, we'll be able to identify what is the prevalence incidence in our population and whether it works or not. So I think Madam will be able to tell us in detail about all those latest IHC panels, markers, what she performs at her center, as well as in a general outline, so that we'll be enlightened, so that we can select our tests wisely. Selecting tests wisely is also important. So select our tests wisely, and for eligible patient, we'll be able to offer those tests. So over to you, Madam.
Yeah, thank you, Dr. Neena, for inviting me for giving this talk today, and thank you, Dr. Sanudev, for that your point of view of the biomarkers. So I will try to do justice to the topic that is given to me. I will focus more on what the pathologists are seeing routinely, how they have to report, how they have to interpret, where they have to be careful of what they are reporting, and what all is important is to convey in the report. So without any further ado, I think I can start my talk. 1 second. So is this screen visible?
Yes, it is.
Yeah, so we'll be talking about biomarker testing in breast carcinoma, which is a topic given to me today. And as Dr. Sanudev said, that these biomarker and molecular tests are used in addition to the traditional parameters of the histopathology report to further classify and select appropriate therapy for the patient, so that we can identify patients who are potentially going to respond to some kind of targeted therapy, to make it cost effective for them, and to spare the patients from potential side effects when the therapy is not going to be effective for them, and spare the patients also from ineffective therapy, so that their tumor responds to those that they are sensitive to. So this starting of this began in somewhere in the early 2000s, when we started doing the ER/PR HER2 regularly. But the guideline for how to practically implement them in therapeutic practice and how they affect the therapy, particularly in breast, came about with the St. Gallen's consensus guidelines in 2013, whereby using ER/PR HER2 and Ki67, a combination of markers, the tumors could be divided into 4 intrinsic major subtypes: luminal A, B, HER2 overexpressed, and razor-like or triple negative. And according to them, treatment recommendations were made as per these intrinsic subtypes. So these were the basic pillars on which the biomarker testing started, and the requirements for optimal ER/PR HER2 testing. This is the very basics from where we have to begin our the biomarker testing. And for that, the ASCO-CAP, the American Society of Clinical Oncology, and College of American Pathologists have time to time issued very good guidelines that should be implemented all across in all labs, so that we are able to give adequate results, not just for these biomarkers, but downstream for molecular testing. These include optimal tissue handling, that the tissue has to be fixed properly in 10% neutral buffered formalin for a minimum of 6 and maximum 72 hours to avoid underfixation or overfixation, both of which can affect the quality of results. The internal validation of both the IHC fish and any other molecular test that is being done has to be done. There should be optimal quality assurance both internally as well as externally, and the lab has to be accredited with appropriate examination of these parameters. And this is very important because particularly in the Indian context, it has been shown time and again that the biomarker programs, especially when you begin, most of the commonly it is done for the breast, it is seen that the basic cause of erroneous results are easily correctable issues in India, which is primarily fixation and antigen retrieval, use of validated antibodies, and interpretation errors. So these deficiencies can be very easily rectified. So this is from the very basics, from where our biopsy, gathering the tissue, fixing it properly, and then applying the test with the optimal features that I outlined have to be put, so that we get accurate result, and this has to be made uniform all across India. So beginning with the ER and PR, these were the earliest, strongest, and well-established predictive factors for the likelihood to benefit from hormonal therapy or endocrine therapy. And the evaluation of ER and PR can be done in a semi-quantitative method, and the nuclear staining for the ER and PR is evaluated. Now, the ASCO-CAP has given various guidelines right from 2010, wherein they defined what is to be called positive, and this was in context of response to endocrine therapy. So what was their interpretation? That if the tumor is equal to or more than positive, 1% tumor is positive with nuclear staining for ER and or PR, it is called the hormone positive. Negative, less than 1%, and this has to be done in conjunction with looking for the presence of internal control tissue. In the negative case, it is important to check whether the internal control has worked or not. So this was given by the ASCO-CAP way back in 2010. Now they gave the basic criteria of 1% positivity, but 1% positivity is not the same as 99% positivity. So could we look at it in a more semi-quantitative manner? So all-rate scoring, or there are multiple other scoring methods like H-score, quick score, they came about. Most commonly used is the all-rate scoring, which kind of gave the background that when you have a staining of zero, negative staining, it is 0. If only one cell, less than one cell, then it is one score is given as 1 according to the proportion, and then 1% to 10% is given score 2, 11% to 33 given score 3, then 34 to 66 score 4, and more than 66 score 5. Now practically what you do is you kind of look at approximately between 1 to 10%, 10 to 1/3, 1/3 to 2/3, and more than 2/3. So this is how the proportion of scoring can be done. And then they also suggest to add the intensity of scoring, which can be 0, weak given score 1, intermediate or moderate given score 2, and strong given score 3, with the total score being the proportion score plus intensity score ranging from 0 to 8. So an all-right score of equal to or more than 3 was considered a good cutoff to predict the benefit for tamoxifen. And when you interpret these biomarkers, ER and PR, it is very important to first check the internal control in the tissue, for which it is recommended that when the tumor section is taken, especially in resections, you should try to include some amount of adjacent normal tissue, so that when the biomarker is put on the same slide, you have an internal control there where you can check. And it should show a heterogeneous type of staining. It does not usually show a diffuse type of staining. It shows a heterogeneous staining pattern. But even few nuclei being positive is important to check whether our IHC has worked or not in that particular tissue. Failing the presence of internal control, yes, external control can be checked on the slide, but there is no better comparator than an internal control on the same slide. So in that context, when we look at ER negative, yes, there is no staining. And this kind of staining would be considered given an intensity score of 3, very strong, and proportion score of 5, almost 100%. So total score would be 8 by 8. In this kind of case, where the proportion score is 5, but the intensity score being moderate, would be given a score of 7 by 8. And in this kind of case, where the proportion score is still 5, but the intensity score is, as you can see, weak staining. So the total score becomes 6 by 8. Similarly, various different types of staining patterns can be observed. You might have a lower proportion score, but higher intensity, 3 + 2, 5, or you have a good proportion, but strong. Similarly, you can see that in the lower panel, you can have good proportion, but moderate intensity, small proportion, but the intensity is stronger. And then you have this specific category whereby you have around 1 to 10% cells with a weak intensity with a score of 3. Now, for this particular population, it was being observed increasingly that they do not respond as well to endocrine therapy as was originally thought. And in fact, many of them behave like triple negative tumors. So because of this reason, in 2020, the ASCO-CAP came up with an update of the evaluation of the ER and PR testing, in which they focused on this particular population, whereby you have a proportion of the nuclear staining is approximately between 1 to 10%. And they have then redefined this category as calling it ER low positive, with a recommended comment. If you have in your slide, the staining is between 1 to 10%. What they have not mentioned the intensity here, I would like to point out. Only the proportion, if it is 1 to 10%, then the cancer has to be called ER low positive, and it has to be given with a comment in your report, the low positive, that the overall benefit of endocrine therapies for this level of patient with low ER expression it suggests possible benefit, but they can also behave like ER negative or triple negative tumors. And this guideline is specifically for ER. It does not apply to PR. So why do we need additional PR testing? We can only do ER testing. Is PR testing really needed? Now, this has been tried even in our lab as well as many places across the world, that can we eliminate PR and just do ER and HER2 where required? What additional benefit is PR giving? Because we are not basically, we are using mostly ER for our classification of hormone positive tumors, but it is an important role. It serves as an informal control, because if you have a tumor which is ER negative but PR positive, that means it is frequently the result of a technical artifact, and it serves as a control that you should maybe go back and check your ER, check the internal control, check if the ER batch is correct, the antibodies has worked properly or not, and repeat it when required. Also, it adds prognostic information by stratifying outcomes in the ER positive population. ER positive, PR positive has a better prognosis than ER positive, PR negative. And it is also used in various tools and nomograms that kind of stratify patients for as predictors in response for neoadjuvant therapy. Also, the very small proportion of the ER negative and PR positive, which is considered a rare biologic phenotype, may be offered endocrine therapies, but they do not have limited data. So bottom line is, yes, we do need to have ER-PR testing to be done simultaneously. And when do you worry about whether your results are correct or not? If you get highly unusual ER negative results, for example, in low-grade invasive breast carcinoma, such as tubular, lobular carcinoma, classic type, or encapsulated papillary or solid papillary carcinoma, if you have ER negative, you must go back and check, look at more sections, Look at your morphology again, whether is the nuclear grade still low. And similarly, if you have highly unusual ER positive results such as metaplastic carcinoma, adenoid cystic or other salivary gland type carcinomas, secretory carcinoma or apocrine differentiation, you have to go back to your diagnosis, grade, take a second opinion, check pre-analytical, analytical factors, and then you must always report this with a comment that this kind of a staining pattern is highly unusual. And if there is another specimen, you should repeat the biomarker in those. What about HER2/neu? Now, HER2/neu is a proto-oncogene. This was well known, which has a very poor prognostic value. But it became, as soon as the targeted therapy for HER2/neu became available, it became a very good marker to have as a predictive marker for targeted therapy. And it was seen that trastuzumab, which is the targeted agent for HER2/neu, it improved the response rate, time to progression, and survival, everything improved. And it is now used as a routine in most patients when they are HER2/neu positive. So how do you evaluate for HER2/neu? Basic is immunohistochemistry, of course, which is first as a screening test. And then you have various in situ hybridization, which is the gold standard, and for detecting the actual gene amplification. These include FISH, KISH, SILVER-ISH, and the more recent one, dual core dual-ISH, which is called D-DISH, which is a combination of the KISH and the SISH techniques. So the guidelines for evaluating HER2/neu also were given by the ASCO-CAP starting way back in 2007. They were further refined in 2013. And in 2013, there were a lot of equivocal categories. To address those categories and the various diagnostic issues, the 2018 guidelines for ASCO-CAP came about, which are the most comprehensive till date. And they say that for the HER2/neu testing, when you're doing by IHC, and they have specified batch controls, on-slide controls, what all you should include, how you should evaluate. If we find a circumferential membrane staining in complete, intense in more than 10% cells, directly you can call it IHC 3+ or positive for HER2/neu. And when there is no staining or staining that is incomplete and faint, or barely perceptible in less than 10% tumor cells, you can directly call it as IHC negative. But then if there is another category, if there is incomplete membranous staining that is more than 10% tumor cells faint, it is IHC 1+. And in that time, they recommended that the weak to moderate complete membranous staining in more than 10% tumor cells be called IHC equivocal. And this was the category which was recommended for reflex FISH testing, ISH testing for this particular category. So according to that guideline, this is HER2/neu negative, this is HER2/neu score 1+, this is HER2/neu score 2+, and this is clearly HER2/neu score 3+ or IHC positive. Now, what about something like this? If we have something in a core biopsy or even a resection, you are seeing at more than 10% cells with complete membranous and strong staining. What do you call this? You are seeing in addition a lot of areas where there is hardly any HER2/neu, but it is fulfilling the criteria of HER2/neu more than 10+. So in our center, we would report this because it is more than 10% complete membranous staining. It would be called positive, but we would also say that there is heterogeneous staining with approximately this much proportion of the tumor showing 3+ staining and this much proportion showing 0, 1 or whatever staining pattern. And we would advise FISH correlation in such cases, FISH or ISH. So in this kind of report, you would have that this is a positive score 3+ with a heterogeneous staining with 3+ score in approximately 20% areas and negative in approximately 80% areas. Now, also it is important to note that not always the tumor have read books and they know that I have to jump into these 3-4 categories only. You can have a different kind of patterns, as I just showed a heterogeneous pattern. In addition, you can have different types of patterns, but that you have moderate to intense but incomplete basolateral staining or circumferential membranous staining that is in less than 10% tumor cells. So in such cases, you should report them as HER2 equivocal, but you may also test for, if you have additional material or different blocks, you can test again and again. You have to check for your antibody validity and the quality assurance. So now coming to the ISH assay. So this ISH assay is basically the confirmatory gold standard for those in which we were doing HER2/neu, IHC was 2+, and then we used to send it as reflect testing for ISH, in which we put 2 probes, dual probes. One is for the centromere and one is for the HER2/neu region. And of course, since we are looking for amplification, when we have amplification, we are going to have only the 2 signals for the centromere, but multiple signals for the amplified HER2 gene. Now the color can vary depending on the probe that we have chosen and the fluorophore attached. So here we have in our center the HER2 new gene is the green and the centromere is the red. So here you can see that this is clearly non-amplified. You have almost equal copies, but here you have multiple copies of the HER2 gene while there is only 1 or 2 centromeric probes. So for how to interpret these, the FISH guidelines also, ASCOCAP has given very nice, in the 2018 guidelines, very nice clear categories were made, which was definitely better than the 2013 guideline in reducing the equivocal categories. So what they suggested was that if you have a HER2-17 ratio more than 2 and average HER2 copy number more than 4, straight away it is called group 1 positive, nothing more to do. If you have ratio less than 2 and copy number less than 2 but more than 6 or 4 to 6, then they were given different names of group 2, group 3, group 4, and they suggested additional workup. Now this is the first time in these guidelines whereby they also integrated the IHC results into assessing how to interpret the FISH result. So accordingly, if you have the group 1, of course, it is positive, and group 5, of course, negative. But if you have group 2 to you have to also look at the immunohistochemistry 3 plus positive. And if it is 2 plus in any of these categories, then at least 20 more cells. Normally, we count 40 cells for giving the ratios, but in these categories, we count at least 20 more cells by one more independent observer. And then we do the calculation of the group again in 60 cells and check what group it is falling in. If it is group of 1 or 5, of course, it can be reported like that. Or any other group, if the group changes, it can be reported like that. Then as per the IHC result, if it is still the same group, if it is IHC 0, 1, or now IHC 2 plus, it can be given straightforward negative with a comment. What are the comments? Now I will not read out the comments. These are given very well in the paper. And all you have to do is whenever you are reporting these kind of groups with these kind of values, as I mentioned, your report at the bottom has to carry these comments that these are limited number of cases. And accordingly, they have not shown any benefit with giving the therapy. That is why they are called negative, and whatever evidence there is. So with the help of this kind of combination of the ISH as well as with the IHC score, we are able to reduce the equivocals. And just for your information, majority of the time, like more than 95%, directly we get group 1 or 5. Only in approximately 5% cases in a high volume center, you might get these odd groups or combinations. So these are some cases in which you will see that the IHC being 3, 2, 1, and 0, and the FISH here is amplified. Here also it is amplified, and in these two it is negative. So when do we have to suspect that your HER2 might be wrong? Where you have discordance with histopathology, where you have a grade 1 tumor that is at least 90% pure of that particular grade, do not have any admixture of different types of morphologies or different types of grades. And then the morphology being tubular, lobular, mucinous, cribriform, or adenoid cystic carcinoma. Again, as I said in ERPR, if you have discordance with the histopathology, you have to first go back and check your diagnosis, and then you have to check, go to the pathway and check the various areas where the IHC or the FISH might have gone wrong. So now what are the limitations of FISH? Though it is the gold standard for detecting HER2 new gene amplification, it is definitely costly and relies on the expensive fluorescence microscope, which is not possible to have in every lab. The signals also fade over time, making archiving difficult. Also, it requires trained personnel and molecular diagnostic facility, which is also not possible to have at every lab. It is difficult to interpret the morphology because you are looking in the dark at something which has lost the cytoplasm, and the nuclei you are looking only and in the high power. It is not possible to have an idea of the of comparison of what area you are looking with the morphology that you saw on the HE or on the IHC slide. Also, it has a relatively high turnaround time. So recently, in 2018, a new technique called D-Dish was introduced. Actually, this technique had been there earlier, but it was not accepted because it also had a lot of technical issues. But a new technique, a new kit was launched by Ventana, in which they launched a new dual-ish DNA probe cocktail, in which they reduced majority of the drawbacks or the previous versions used to be having. And it was more importantly, it was easy to perform on the standard Ventana benchmark instrument, which most of the labs have for doing IHC. So it is fully automated. It has a very short turnaround time, and it allows concurrent analysis of the tissue morphology with the HER2 gene status. For example, if you can see here, now HER2 signals in this D-Dish appear black, while the centromere signals appear red. So you can see that along with the morphology, you can make out where the tumor is, where the DCIS is, which is the stromal cell. You can make out and compare with the morphology because this is under conventional light microscopy. So also the signals are permanent, just like immunohistochemistry. So the slides can be stored, archived, discussed, shown around. And the most recent kit also reduces non-specific hybridization. So the results were said to be very good. But we tested this. We tested this kit. We tested around 150 cases of our in our lab against the gold standard fish, and we found not just tested the directly, we also tested inter-observer reproducibility of the D-Dish amongst reliably assessing the non-amplified cases, as well as majority of the amplified cases were being adequately assessed. And we found that the advantages of D-Dish were very great, looking at the disadvantages of fish with the longer turnaround time, morphology, and everything that I said. So it was a very, very useful test, and it could be we put a caveat that the consensus decision and reflex fish testing should be available in difficult cases. So this was our sensitivity specificity for the D-Dish versus fish, and after successful validation, we introduced it into routine practice. So in 2022, we standardized the kit. And in 23, we introduced it in a routine service. And as you can see, this is our fish and this is our D-Dish. So over time, our D-Dish tests are gradually increasing and fish are reducing. Actually, this data is only till the February 24. So it is the current data is much more stark than majority of the tests are D-Dish, while fish are only few. So we have successfully validated and introduced it. And I can tell you that we do find it much more comfortable and easier to report, and we can see it reporting on our microscopes only rather than having to go to a dark room for the fish testing. So these are some of the cases that I showed in fish, and you can see the D-Dish interpretation also very nicely, very similar to what you see in the fish, that one centromere and the 1 or 2 centromeric probes and 1 or 2 HER2 probes. And this is a non-amplified case. This is an amplified case. And these are some of the other 1+ and 2+ cases, which here is showing non-amplified and here it is showing amplification. Now coming back to the core biopsy I showed earlier, which was showing heterogeneous staining. So D-Dish actually particularly helps us identify this very nicely. What is this? This is a cluster heterogeneity. That what we saw in HER2, there is a clearly amplified area. So this we can identify the cluster heterogeneity very nicely on D-Dish because it gives a very nice correlation with the morphology. And you can see on the adjacent to it is the non-amplified area. So how do we report such cases? We report these cases as it is because technically it is fulfilling the criteria for amplification. So it is an amplified D-Dish, but the tumor shows intratumoral genomic heterogeneity of the cluster type with distinct amplified and non-amplified areas. And we give separately the count of the amplification in the amplified areas and in the non-amplified areas. So can we do away with fish now that we have D-Dish? So D-Dish we have found that it is more sensitive to pre-analytical factors such as fixation and storage as compared to fish. Fish is a little bit more resilient. So there are some certain instances wherein the fish D-Dish might be uninterpretable, especially in old blocks or little bit fixation issues. But in those cases, we have found that in about 2/3 of them, D-Dish still works. Fish still works. Also, we have to be vigilant while interpreting cases with heterogeneity and polysomy in D-Dish because of the counts can be a little difficult to interpret because of the little bit of overlapping of the signals. So these cases and those uninterpretable by D-dish require repeat testing by FISH to appropriately classify them. So as we said, a consensus decision and reflex FISH testing should be available even if you are doing D-dish. You can possibly ask for a FISH in cases where you have difficulty in interpreting D-dish. So in our own data, when we analyze about 892 cases by D-dish, only about 2.4 were uninterpretable and 5.8% in total were asked to be repeated by FISH, and with only 11 cases with 1.2% showing discordance. So as you can see, in majority of the cases, your D-dish, you are able to interpret as well as report, but you should be having a facility or at least an option of referring out cases if in case your D-dish result is, you feel is not reliable. Now, this was till 2022, what was, everything was very well known. We were very comfortable reporting FISH, D-dish. Now this here came the landmark paper that has changed and stirred up the bowl a little, and it has been a game changer. This was the paper in New England Journal of Medicine in July 22, which gave a new drug called trastuzumab deruxtecan, which was an antibody drug conjugate in HER2 low advanced breast cancer. So the logic of the drug was that a large proportion of patients who express low levels of HER2, but they still might be targetable. Until then, the HER2-directed therapies were ineffective in these HER2 low cancers. So what was HER2 low? This paper actually defined HER2 low as the score of 1+ on IHC or a score of IHC 2+ with negative results on ANC2 hybridization. They tested this drug only on this particular set of patients. And as you can see, they were able to give, on giving this particular drug combination, they were able to show significantly improved survival of the patients of these advanced HER2 low breast cancers when this drug was given compared to when this drug was not given. And what was so special about this drug? So actually, this drug is an antibody HER2 conjugate, which has this trastuzumab, which binds to the HER2 receptor on the cell cytoplasm, and it can bind 8 molecules of the drug target, which can be conjugated to it. And once it attaches to the HER2 receptor on the cell, it internalizes, and these drugs are then released from the trastuzumab, the antibody conjugate, into the cell. So not only do they then go to the nucleus and kill the cell, these are membrane permeable. It is called a payload, drug payload. It is membrane permeable, and so not only does it kill this particular cell, it can also diffuse into the neighboring tumor cells, which may or may not be HER2 positive, and by a bystander effect, it can kill those also. So this was a game changer drug. Now, the antibody drug conjugations even at that time were not something new. We already had a drug called TDM1, in which you had similar trastuzumab combined with another drug in which only 3 molecules were attached. And this also drug, when you gave it, would go to the receptor, go into the cell, and it would kill, but it would target only HER2 strongly positive cells. And it was used mostly for refractory cases of where the trastuzumab was not working. But here, in this particular case, in trastuzumab deruxtecan, it is not only killing the HER2 positive cell, it is diffusing here and there. It is delivering a huge payload of 8 molecules of the drug, and it is killing the adjacent cells as well. This result led to the rapid approval by regulatory agencies and implementation of international this combination in international treatment guidelines. And now suddenly pathologists were being tasked on how to accurately and reproducibly identify HER2 low breast cancers. And not only this, as Dr. Sanudev said, the spectrum of HER2 low is also being expanded more and more. So now you have what is known as HER2 ultra low. So in the scoring, if you remember, between 0 and 1 also you can have some amount of less than 10% staining. So they say that what HER2 low, HER2 negative or HER2 null should be completely absence of staining. But even if it is between 1 to 10% staining, it is what is being called as HER2 ultra low. So there is potential expanded spectrum of HER2 positivity that is soon coming up. But for us pathologists, there are a lot of issues how to go about giving a diagnosis of HER2 low. There is a very nice article in last year by Stuart State, who have kind of summarized these issues that pathologists are facing in giving this kind of diagnosis, because the IHC assays that are used in the FDA approval of trastuzumab many years ago were intended to identify high levels of HER2 protein overexpression. Now, even though our methods have become more sensitive and the IHC techniques are much better, they are not developed to have the sensitivity or range to reliably identify tumors with low level of protein. Also, in immunohistochemistry, when you're giving a report, you can the differentiation between HER2 0 and HER2 1 plus, it is many times, because it was called just HER2 negative. In many labs, they used to be just called negative without further classifying whether it is 0 and 1. Also, as you very well know, pre-analytical and analytical factors will have a great impact in what we are calling as 2 plus, 1 plus, or 0. So again, identifying these HER2 low cases becomes a little difficult. Then also the distinction between 0 and 1 is also subject to considerable inter-observer variability. If you show 10 pathologists something between 0 and 1, somebody is going to call it 0, somebody is going to call it 1. Also, the HER2 low phenotype was also seen that it changes over time, that some cases convert from 0 to 1 plus and vice versa. And so that also is a difficult situation, that how do you now report this? Earlier you have called it 1 plus, now do you call it 0? There is also another ongoing trial, DAISY study, in which the limited results are available, that have said that trastuzumab deruxtecan may act even in HER2 0 tumors with a response rate of approximately 30%. So even when there is no HER2 low, even when it is HER2 null, the drug combination might act because it is so effective. Because even if you know HER2 0 tumors, it is not that the HER2 receptor is not there. The normal copies are always there, as we have seen in the gene amplification and the IHC. There is always the gene is there and some amount of protein, even if it is undetectable, below detection levels of the HER2 IHC, the normal HER2 receptors are still there. And this drug being so effective might even be effective in those tumors. There is another ongoing trial for this subset of HER2 ultra low, though they have not included HER2 null, that might show that this drug is effective in the ultra low as well. So if the HER2 0 tumors are showing the similar response as HER2 low, is it relevant to really distinguish 1 plus from 0 cases? It might not be clinically relevant, maybe once the trial results are out. But as of now, what do we have to do? As of now, the drug is there, the trial is there, it is being implemented, and the drug is available, but still it might be expensive, but it is available. So according to this, it was being asked all over the world to pathologists, how to report this. So the ASCO CAP came up with an update specifically targeting this particular question, that how to report HER2 low by pathologists in the routine immunohistochemistry reporting. And they have said that you have to continue to score HER2 IHC using the 2018 ASCO CAP guidelines. And but here you have to be careful that yes, you have to use high power to distinguish 1 plus from 0 staining, and give it as, even if you're giving it as negative, you have to say whether it is 0 or it is 1 plus. You should also review by a second pathologist for borderline cases. You can take a second opinion whether you're not sure. You will be feel free to take a second opinion whether to call it 1 plus and 0. You should use controls on the slide with a range of protein expression. That not earlier we used to use 0, 2 plus, and 3 plus as the external controls with batch to batch staining. But now you have to use 0, 1, 2, and 3 all on the all the controls in every batch to check whether the 1 plus is accurately working. Also, you have to pay careful attention. If you are not paying already, you have to pay careful attention to pre-analytic factors. And also they recommended to include a comment in the HER2 report stating that patients with HER2 1 plus or 2 plus staining without amplification may be eligible for certain targeted treatments. But what does this guideline update not do? It does not recommend using HER2 low terminology in the report. It says you give the score. It does not say call it HER2 low, because there is no evidence that HER2 low is a new or a reproducibly defined subtype of breast cancer with distinct prognostic or predictive implications. It is a type that was given by the paper to define the population that they chose, but there is no separate breast cancer that is specifically HER2 low. And also, it is not possible when you are giving the IHC report. You can call it 1 plus and 2 plus. You cannot call it HER2 low for 2 plus cases, because the FISH has not been done till then. That can only be done after the FISH result, that it is negative, that it can be taken. But when you are reporting the IHC result, you cannot call the 2 plus as HER2 low. The guideline update also does not recommend changes to the traditional terminology of positive, equivocal, and negative for the IHC result. So this is the stand of the ASCO CAP as of now. It does not endorse newer methods of detecting HER2 also at the present time, but they say that newer technologies to detect this HER2 may be introduced if a clinical need persists after the results of these trials are ready. So there are a number of other techniques. If you go to any international conference right now, more than half the papers there are on detection of what different techniques and tests are being developed to detect this HER2 low, which includes the RT-PCR based test, the automated quantitative analysis for the antibody intensity, quantitative IHC technology, multiplex MLPA, and time resolved fluorescence energy transfer besides automated AI. So as of now, that is the current situation. You have to report, but we have to follow the ASCO-CAP guidelines in reporting the terminologies, and after the FISH test is available, then only it can be decided whether it is HER2 low or not. Besides this, I just address briefly some of the special situations which are asked frequently. Do we need biomarker testing on DCIS? Now, until 2010, there was limited data and there was no formal recommendation on how to address biomarkers in DCIS. But after the 2012 NSABP trial, it showed that a significant reduction in relative risk of subsequent breast cancer was seen in ER-positive DCIS given endocrine therapy. So this has also been supported by a number of other studies since then. So the expert panel ASCO-CAP now recommends ER testing in DCIS to guide discussions about adjuvant endocrine therapy with the patient. But what about HER2? Now the routine testing of HER2 in DCIS is unclear. But we do know very well that if it is HER2 positive DCIS, the Komodo type, the high nuclear grade type, extensive DCIS, it has increased risk of recurrence and it is negatively correlated with the ER and PR expression. It is in the guideline currently, it is not recommended to routinely test for DCIS for HER2, but in India, in most of the centers, if there is a huge palpable DCIS, large DCIS, definitely HER2 testing is recommended. Do we need biomarkers on when there are multiple tumors? If the tumors are bilateral, yes, right and left are assessed and staged independently. So we do need biomarkers on right and left independently. But if there are multiple tumors in the same breast, generally only the largest invasive focus is required to be tested. And only if the other smaller areas, if we identify in the resection are of different histological type or higher grade than what has been reported, then they need to be tested. Otherwise, only one single test for one side is enough. Also, do we need to report biomarkers on microinvasive carcinoma? Now, ASCO-CAP says that biomarker testing has to be performed on all primary invasive breast carcinoma. They have not specifically mentioned microinvasive, and even the NCCN and St. Gallen guidelines are a little ambiguous on the role of biomarkers in the microinvasive carcinoma, but the data suggests that they are suitable for adjuvant treatment strategies, because especially most of the microinvasive carcinomas are in context of the high-grade Komodo type DCIS, which are HER2 positive. So in a very recent paper, there are some suggestions on how to report biomarkers on these microinvasive tumors. So they recommend that you should definitely try to do the biomarker after confirmation that this is a microinvasive carcinoma. It can be performed on the core needle biopsy, but if on the resection you see larger focus of invasive carcinoma, then it needs to be reported on the larger focus. And if there is confirmed that this is only microinvasive invasive carcinoma and not a bigger tumor, it should be performed on you can perform it on one representative focus. It does not need to perform on the other multiple foci. And it is recommended that you should try to minimize the tissue loss by taking, consecutive sections and trying to preserve, because if it is a small microinvasive focus, it might get lost. Now, interpretation is definitely difficult because you're not having, many times, not even 100 cells. So the interpretation might be difficult, but that is, it does form a part of primary invasive breast carcinoma. So that is how you have to report it, that the biomarkers have been tested on the microinvasive focus, which is of this size. Now, also, there's a question many times we wonder that when do we repeat the biomarkers, what's already been done. So as per the ASCO-CAP guidelines, if there is anti-invasive tumor in the core needle biopsy, you should definitely repeat it in the resection. If you have reported, like as I said, in a microinvasive, or if only very small, tiny part of the invasive tumor is identified in the needle biopsy, and you have proper big tumor in the resection, you must repeat it on the resection. If you have a morphologically distinct carcinoma from the core needle biopsy, it is either higher grade, as I said, or different morphology, it has to be repeated. If you have obviously equivocal and uninterpretable HER2 results, even after doing IHC and ISH, it is better to repeat it on the resection. If you have doubt on the integrity of your core needle biopsy, that whether, the fixation, the cold ischemia time, the internal control is negative. If there is doubt on the integrity of the core needle biopsy, you should repeat it on the resection. Also, in the context of post neoadjuvant settings, there are certain guidelines for when to repeat biomarkers. In addition to what has already been said by ASCO-CAP, they also recommend that where the tumor did not demonstrate any response to therapy, this is very important. That means that the tumor was given certain therapy based on the biomarkers reported on the core biopsy, but it has not responded well. It is always advisable to repeat the biomarkers in such a setting. So we did a study in which we assessed the concordance of biomarkers on reassessment, and in around 1100 cases that we tested, we found that the concordance for ER was around 85% with the core with the initial initial evaluation. Concordance was PR was lesser, around 77%, but it is known that the PR is definitely a heterogeneous stain. And concordance was HER2 when confirmed by IST status, it was very good, around 94%. Now here, if you see that the HER2, the ER, what we call as low ER, which would be almost correspond to score 3, 4, 5 in the all-red scoring, majority of them on re-evaluation turn out to be ER negative. So that is the basis on which the ASCO-CAP has recommended giving a comment on low ER status. And this way also tested our population for the molecular classification, that how much frequently does the molecular classification change. So here also, if you see, in majority of the cases, the hormone positive is what changed, the low ER status changed to TNBC, while in a smaller proportion of cases, the TNBC changed to hormone positive. And this could be because the initial tissue was poorly fixed, so it turned out to be a triple negative, which was possibly not a biologically triple negative. The other classes changed much less frequently. And why do these classes change, especially after treatment? It is said that it could be emergence of a subpopulation or subclone which is resistant to the therapy given, and they might be intratumoral heterogeneity, as we very well know that can occur in multiple tumors. As per results of our study, we found that reevaluation was not routinely required between initial core needle biopsy and upward resection, or for evaluating HER2 status alone, except for fixation issues and the other issues, scanty tissue, etc., that was highlighted in ASCO-CAP. But we do recommend it that we should reevaluate the biomarkers if there has been a long time between evaluation and we have a fresh material. In patients receiving specific or targeted therapy when there has been no response, any distant metastatic site or absence of internal control in the initial material, and referral material with suboptimal fixation, especially in cases with initial TNBC status. Now coming to Ki-67. Now, it was included in the prognostic and predictive factors for breast cancer way back in 2009, and it was shown to have importance in risk stratification of ER/PR positive tumors and for risk of recurrence and death. And it is, of course, one of the most important parameters included in multigene assays. It is evaluated using the MIB1 antibody, and nuclear staining is counted in 1,000 nuclei to give a percentage of MIB. And as again, St. Gallen's guideline used MIB as a very important factor in subclassifying tumors into luminal A or luminal B HER2 negative, using 14% as a cutoff at that time, which was later revised to 20%. But there are numerous pitfalls, as we know, in Ki-67 evaluation, and that is the reason for majority of the solid tumors, you will not find a specific cutoff being identified for saying that this above this cutoff or below this cutoff is significant, because the clinical validation of these Ki-67 is difficult. The high and low values are reproducible and useful, but the optimal cutoff is difficult to achieve. Standardized fixation, processing, and IHC staining and interpretation is difficult across the country, as we very well know. And the cutoff, originally, though it was called 14%, it was revised to 20%, which is what we use currently. But these cutoffs also have been found to be a little variable and might be subject to lab variation. So for these reasons, the routine testing of Ki-67 in all cases is currently not recommended by either ASCO or NCCN, and the clinical utility is limited to the ER/PR positive, HER2 negative tumors, which are low stage, and to decide on whether they should receive adjuvant chemotherapy or not. Now, this has this particular issue was also addressed by the International Ki-67 in Breast Cancer Working Group, whereby they assess the concordance of Ki67 between a large group of assessors, and they found that the concordance was high only when the Ki67 was less than 5% or more than 30%. Then there was near unanimous concordance. But so these thresholds are of utility in deciding treatment without any gene assays. But between 5 to 30%, they said concordance is below acceptable. So if the result was between 5 and 30%, it is not possible to use one particular cutoff and say that below this you should give chemotherapy or above this you should not, or vice versa. So it was also discussed in a lot of other forums, and it was said that especially in India, if the Ki67 is high, that means the IHC has worked properly and it is high, that may still be used to give take the decision of chemotherapy. But when it is low, you cannot never be completely sure whether it is not due to other analytical pre-analytical factors. So the utility of Ki67 is a little limited. So coming to the next buzzword of the day, that role of automation in biomarker evaluation. Now, the automation on AI has many advantages over manual interpretation. It reduces the interobserver variability. It minimizes equivocal results, and it is also being used to accurately predict the important biomarkers. We have used some of these AI-based algorithms successfully in our lab to look for concordance between manual evaluation of ER/PR, HER2, and Ki67 using these image analysis algorithms. And this has been found that there is very good concordance as well as good sensitivity of one of those algorithms that we use, that is the VisioFarm algorithm for identification or diagnosis of these biomarkers. In addition, we also have validated the UPath Roche for evaluation of HER2 IHC for concordance. And also recently they have launched a AI-based test in which you can assess the D-dish. But the slide that I showed you, the D-dish slides can be digitized and scanned, and it automatically just you have to select the area and it counts the 20 cells with giving the ratio of the individual cell count, the HER2 signal count, the CEP17 count, as well as the ratio in those 20 cells, and telling whether it is amplified, non-amplified, or equivocal, giving the score as well. Now, the advantage of this test, we found that, of course, the sensitivity, specificity, etc. was good as we expected. But main important was that it reduced the time from manual evaluation of each cell or each slide being counted from a good large time to a very small time. As you can see, this was a very significant time reduction in analysis by using the AI analysis. Coming to multi-gene assays, now several times, as I said, that there is a lot of utility of the ER positive, HER2 negative cohort, in which the decision has to be taken whether chemotherapy has to be given or not. And a number of multi-gene expression assays are available, which give risk prediction score, whether depending on the parameters or the gene analysis with mRNA expression that is done, that whether the tumor is likely to progress, the risk of progression or recurrence is there or not. So the scientific rationale being that there is diversity in gene expression at the mRNA level, and these mRNA assays then identify specific tumor subtypes and improve our ability to assess the likelihood of response to specific treatments. But the drawback being that most of these assays are proprietary, developed and performed by a single particular lab, and are very, very expensive. They're definitely out of reach of majority of our population. The methods that they use are quantitative RT-PCR or DNA microarrays, and a number of such tests are available, most commonly and well-known of which is the Oncotype DX. But there are others called ProSigma, Breast Cancer Index, EndoPredict, MammaPrint, which predict the recurrence of different tumors and accordingly the decision for chemotherapy can be taken. Now, additional markers in TNBC, now which is a specific subtype. The tragedy of TNBC is that though it forms about 15% of breast cancers, and in India, actually, it is considerably higher. They have the worst 5-year survival rate because there is no known driver or target for developing a therapy in the routine run-of-the-mill TNBC. They, of course, do not benefit from endocrine therapy or trastuzumab, And currently, conventional chemotherapy is the mainstay treatment modality, but more than 50% do not respond to such chemotherapy. So development of targeted therapies is crucial to improve the outcome. Way back in 2011, the multiple molecular subtypes of TNBC were identified, which were immunomodulatory, basal-like, luminal androgen receptor-like, mesenchymal, unstable or mesenchymal stem cell-like, and a number of molecular or cellular targets, as well as drugs are being developed against each of these different subtypes, and a lot of work is ongoing in trying to improve survival of this particular type of category of patients. So I'll be enumerating some of the targets that are available right now in the lab and can be utilized easily directly. So this includes the immunohistochemistry for androgen receptor. Now, this is usually associated with apocrine histology and shows better prognosis of TNBC. And it can be targeted by specific AR inhibitors. We have to remember that in general, androgen receptor is positive in nearly 70 to 90% of breast carcinoma. So the one that we are looking to target is the TNBC type, in which it is present in around 15 to 20%. So this is the kind of morphology that we are looking for, that the cells have abundant, granular, foamy cytoplasm, oncocytic looking like, with vesicular nuclei and single distinct nuclei, and they turn out to be diffusely AR positive. But what are the criteria for calling AR positivity? There is no ASCO-CAP guideline for AR, and most studies, there are variable cutoffs used. Some use more than 1% nuclear staining, similar to ER-PR, but most therapeutic staining studies use more than 10% nuclear staining. At TMH, we do testing for androgen receptor that is requested in relapse or refractory TNBC, and we report the nuclear positivity percentage and intensity, but we do not assign it any all-red score. Coming to another buzzword of the day, that is the PDL1. Now, as we all know, the PDL1 assays are have been found to be good predictors of response to various immune checkpoint inhibitors. But what about the breast? We know very well about the PDL1 assays we are using very frequently in the lung and in the GI. What about the breast? Now, PDL1 protein expression by IHC is currently the only clinically applied predictive marker for immunotherapy in triple-negative breast cancer. It is relevant in unresectable, locally advanced, or metastatic setting. But again, as we all know, PDL1 evaluation varies, that each immune checkpoint inhibitor comes with a companion or complementary IHC assay. The antibody scoring system, definition of positivity, and predicted threshold is different across the different assays. And there is a lot of temporal and spatial heterogeneity as well. So first, initially, the clone that was identified as being useful in triple-negative breast carcinoma was PDL1 SP142, which was predictive of response by atezolizumab. And this was in the Impassion 130 trial. It demonstrated significant benefit in OFS and PFS, and it was granted accelerated approval. But as you can see from the graph, there was good response. However, the continued approval of the agent was contingent to result of the subsequent trial being done on the population and subsequent result. But the Impassion 131 as well as 132 failed to meet the endpoints of PS and OFS, because of which this drug atezolizumab was withdrawn by the manufacturer after talks with the FDA for TNBC. It is still useful in some other cancers, but not for TNBC. So now, when we had received training and we have introduced the test in our lab, suddenly from 2019, and this was happened in 2021, 2 years later, suddenly we found that no, this assay is no longer useful. So now what was present? Now PDL122C3 by PharmDX by Dako. This was for the companion diagnostic test for pembrolizumab, and it was seen that in patients with CPS of more than 10%, there was significant improvement. So this was approved by the FDA in November 2020 for patients of TNBC with CPS more than 10%. But and also this drug fortunately showed a consistent result. So it was also approved subsequently for high risk early stage TNBC in 2021. And so, but also you have to remember that we have only 22C3 PharmDX by Dako. Earlier we had all started testing SP142 by Ventana. It is recognized that maintain the companion diagnostic platforms for the predictive pathology of all different solid tumors. In most laboratories, you are having different platforms for different different clones and different companies, it is challenging and impractical. So there have been a multitude of studies which have assessed the interchangeability of different PD-L1 assays across the tumors and with good inter-reader agreement. So consequently, both the 22C3 and they can be reliably conducted in metastatic TNBC for their respective DAC1 Ventana platforms as per availability. But if the you have to also remember that the approval has been only for 22C3, but PD-L1, if you have a Ventana machine and you can do SP263 as an interchangeable assay, subject to the comment that this is on the Ventana machine. And how do you calculate CPS? You calculate the proportion of the tumor cells that are showing positivity. You calculate the proportion of the immune cells that are showing positivity. You combine the two and you get a composite proportion score. That is the proportion of the tumor and immune cells that are showing positivity, and a cutoff of 10% is defined. Other biomarkers currently under investigation for immunotherapy, including TILs, immune phenotype, tumor mutational burdens, and BRCA are also being studied, but because of lack of time, I will not be able to cover all of them. Just another word about PIK3CA. Now, this is reported prevalence of PIK3CA mutations in around 20 to 45%, majority of this in ER-positive breast cancer, and they are associated with the worst prognosis with endocrine monotherapy or non-PIK3-based therapies for metastatic breast cancer. But this is again targetable. Alpelisib can be used, and a lot of new drugs are being developed for targeting PIK3CA mutated tumors. And the methods of detection include the quantitative PCR, the NGS, and liquid biopsy. At TMH, we have used NGS as well as quantitative PCR, and we have seen this in around 17.5% of the tumors we tested, of which the HR positive were the majority, but a good number of HER2 positives were also there, while the least positive for PIK3CA were the TNBC. So I would like to thank my colleagues in the breast DMG, Dr. Sangeeta, Dr. Tanuja, Dr. Asavri, Dr. Prukti, Dr. Poonam, Dr. Prarthna, and members of breast DMG, and my residents, several of whom have worked on the studies that I have shown here. And I would be happy to take questions.
Thank you, madam, for a wonderful and elaborate discussion about almost every biomarkers, as well as when ER, PR, HER2 testing, and DCIS, and rare histologies, PIK3CA testing, and it was an elaborate, for last 1 hour, you have covered almost everything in the breast setting. So nowadays, we are doing repeated biopsies. Maybe if patient develops a recurrence after we saw one year, after 1 year or so, we do biopsies, and at every recurrence we need to do a biopsy. I may stop at 2 or 3, but guidelines say that you need to do repeated biopsy because this will be changing. For ER, I think it is reported around 20%. PR, it is slightly higher, maybe 30%. HER2 will be lower, like 10 to 15%. Madam, what is your experience like? Do you do repeated biopsies and you see ER/PR status?
For metastatic, distant metastatic settings, at least we try to get one tissue, either even a cell block or a tissue core, we try to get from the metastatic site for repeating the biomarkers, because as you said, we ourselves in our data also, at least 1 in 5 patients, we have seen that the biomarker changes after in the metastatic setting. And it can be, the reasons can be many, as I have elaborated many times, the reasons could be many, but the fact remains that it changes, and it gives if there is a receptor conversion to positive, then it gives an option for adding a therapy. And if the receptor conversion is negative, then at least you can remove the therapy which was no longer effective. So it is definitely important to repeat the biomarker if there is a fresh tissue available. Now here the caveat being the bone biopsies. Bone biopsies, they undergo decalcification. So the results become a little unreliable. If they are positive, then you can rely on them. But if they are negative, then it is very difficult to say whether it was, due to the decalcification process.
Yeah, bone biopsies are always a problem whenever IHC and molecular tests are concerned. We do face the same problem. Other sites, I generally go for an accessible metastatic site, preferably. If that is not possible, I may have to take a biopsy from a node or breast lump per se. And
actually we have, in our experience, HER2 remains relatively stable if both the times the testing was confirmed by ISH. If it was only IHC based, then it can go in any direction.
yeah, and nowadays, no, I mean, we do rely on response to chemotherapy. Response to chemotherapy is, I mean, it's also a so-called biomarker to predict on treatment, like triple negative patients who don't have a proper, they have a path, they do not have a path CR. We have now data to add capecitabine. And those patients who are HER2 positive treated with trastuzumab or trastuzumab pertuzumab, they don't have a PCR, we may change to TDM1, another molecule for rest of the therapy. So biomarker, I mean, I don't know whether I should say they are also biomarkers, but they will, like, when they will help you to change the therapy. It's not ineffective. The therapy is not ineffective, but still, if you change the drug, there is benefit in overall survival and progression-free survival. Yeah, and
by ineffective, I meant that the biomarker receptor status has changed to negative.
Yeah.
Then that, like giving trastuzumab when it is not HER2 positive anymore, or endocrine when it is not ERPR positive, or at least in the metastatic site it is not positive, it might not be effective for the patient.
Yeah. And another important thing is that choosing neoadjuvant therapy, like even if the patient is having a larger tumor like T3, elderly patient, ERPR is strongly positive, HER2 negative, low key, I may straight away go for a mastectomy or a BCS. But HER2 positive, if I came to know, in our place and we takes time, in medical college, it takes time to get the HER2 report, IHC report. So maybe it will take like 3 or 4 weeks, even in a locally advanced breast cancer where we need to start. So for those subset, ERPR will help you. If it is high, then preferably we can go for primary surgery. And HER2 positive, triple negative subset, we may need to go for a neoadjuvant strategy. So PCRs can predict survival in those settings. So I think that will be the practice everywhere. So with that, I think I will open. Madam, there are a couple of questions. Shall I read it out for you?
Yeah, please.
I'll open it for discussion. Ma'am, currently your experience on HER2 positivity in mucinous carcinoma.
Yeah, so there is a subset of mucinous. Actually, this question was asked last week also. So there is a subset of carcinomas called micropapillary mucinous, which is included in the WHO 2019 classification of breast cancer. This carcinoma actually looks like mucinous carcinoma, but if you see the pattern, the cells are arranged in a micropapillary fashion, and they have the nuclear grade is not low. So as I mentioned that mucinous carcinoma, if it is pure, at least 90% mucinous with low nuclear grade and grade 1 only, then there is hardly any HER2 positivity ever. And it would be considered a discordant result. But you have to be sure that you are not looking at a micropapillary mucinous, which can be HER2 positive in a good number of patients. So you have to again look at your morphology and check whether your diagnosis is correct.
We have another question from Dr. Lashmi Anu. What about hormonal status in neuroendocrine tumors? If positive, can they be used as a clue for mammary origin?
Actually, I think, Dr. Anina, this was discussed last time in biomarkers, in the core biopsy interpretation on neuroendocrine tumors, that I would not suggest that using neuroendocrine markers as a clue for mammary origin, because the majority of the breast carcinoma are mammary, but the mammary origin can also be showing some amount of neuroendocrine tumor marker positivity, but that can be very well metastatic also, or the neuroendocrine marker themselves are not a marker of mammary origin.
I think I didn't get this context actually. Whether it's a like unknown primary.
I think Dr. Nina would agree with me.
Yeah, I mean, not I didn't get the context of this question. Whether it is like carcinoma unknown primary with metastasis.
So, I think the question was what is the hormonal status? Meaning, how does the hormonal status help to decide whether it's primary mammary or
origin of
metastasis to breast?
endocrine tumor?
That is the question.
Okay. Yeah, then another question from
So many of the neuroendocrine tumors, as we discussed last time, they can show ERPR positivity, but that in itself does not prove, because if suppose it's a neuroendocrine tumor in a female, there might be some amount of low level of ERPR expression also. So that is, I don't think as it is used as a marker of origin of breast origin if you have hormone positivity in a neuroendocrine tumor. That is not what it is used for.
Yeah. There's another question from anonymous attendee. Ma'am, are you using TRPS1 as mammary origin marker, especially in TNBC, where GATA3
Yes.
becomes inconclusive?
Yes. So we have a good experience with TRPS1 since almost 2 years now, and we have used it across a variety of tumors in the body. And in triple negative, when the GATA3 becomes weak or focal and little inconclusive, TRPS1 is strongly positive, provided you have ruled out a gynec cancer like ovarian carcinoma. Ovarian and endometrioid carcinoma can also show TRPS positivity and GATA3 negative. So PAX8 and WT1 should also be negative. And there are some rare TRPS1 false positivities in different tumor, but by and large, it is a very good marker for breast origin, provided the GI malignancies have been ruled out.
Okay. And another question from the same person. Is Ventana lock protocol necessary to assess HER2 low?
Currently, we are using the Ventana lock protocol for the HER2 assessment by the Ventana machine only.
And next question, is it IC percentage or CPS that has to be done in TNBC?
So that is what I wanted to tell, that the SP142, which used to check the IC, has been discontinued because the drug atezolizumab is no longer effective, not been found to be effective. So that indication has been withdrawn. So if the indication is withdrawn, its companion diagnostics, that is SP142, has also been withdrawn. So we no longer check for IC. If we are using SP263 or 22C3, we check for CPS. And that CPS is only been found to be significant for combination of pembrolizumab.
Shall I answer? Shall I add on to that for this question?
Please.
Because for triple negative neoadjuvant setting, the trial, they have not tested for CPS or any PD-L1 markers. They've just given chemotherapy with pembrolizumab for almost every patient. But I do send for PD-L1. I send for SP263 only when I use neoadjuvant pembrolizumab. Metastatic setting also, I use SP263. CPS score, I'll check CPS score. If it is more than 10, I'll add pembrolizumab. That's how do we practically in the clinic.
So it is very helpful for the pathologist if the medical oncologist specifies, what clone or what drug they are, looking for when they send us a request for PD-L1.
Yeah,
it is very helpful for the pathologist, because which clone to apply, because the drug combination, there is no use in putting SP142 when you're giving for pembro.
Yeah, but the other thing is that SP263 is bit widely available and it is cheaper. It comes around 4,000 to 5,000.
I fully agree with that. That is why the number of studies that have compared the equivalence of 22C3 and SP263 are very helpful, because Ventana is a more widely available platform.
Yes, madam. I also use that one only. Next question is from Niveda. Ma'am, what about COX-2 in breast cancer? Is there any scoring system there? Because many targeted therapies are under development, like for colon cancer, COX-2 inhibition, like we have used prophylaxis with ecosprin for colon cancer. There's some data showing that it reduces the risk.
I do not have any experience. It is not being used in our institute as of now. So I will not be able to tell, because I do not have any experience in testing this for breast.
Yeah, we also don't do any research also on this topic. What about the experience on biomarker testing on cell blocks? Any cutoff for number of tumor cells to be there for accurate reporting?
So this again, I should have addressed this in my special context issues. So as I said, for microinvasive, similar actually criteria apply for cell blocks, that you should try to preserve the tissue and everything. And the ERPR testing being the paper that I referred to for microinvasive, they said that since the ERPR testing says percentage in 100 cells, they say at least 100 nuclei should be present. But that might not be practically possible or not present in the same location, especially in a cell block. So what they practically do is you report it on the proportion that you are seeing. But if you feel that it is too scanty to report, you can very well say that it is too scanty and this has to be taken in that context. It might not be an accurate representation if the cell block does not have enough number of tumor cells. There is no defined cutoff criteria. Of course, the more the better. But as of now, the ASCO cap has not addressed this issue of number of tumor cells to be required in cell block.
I think that clarifies. Madam, in between there was some interest on fine needle aspiration biopsies. So now I think there's not much interest. You go for a true cut. That's the
yes. Always true cut. Always core biopsy. Yes.
Next question is from Sati, madam. HER2 status in solid papillary carcinoma, ma'am. What is your experience?
So again, as I said, this morphology is one which, if it is pure, more than 90% solid papillary with a low nuclear grade with ERPR positivity, you should be very wary of calling it HER2 positive. And again, go back and check your morphology, mitosis. You might even try to do a MIB that suppose solid papillaries, are supposed to have very low MIB. So if you have something, as I said, again, cutoff being 5 and 30 are as of now reliable. So if it is something very mitotically active, then the diagnosis might not be solid papillary, and then you might in that case have a HER2 status positivity. And again, if you are completely sure of your morphology and the quality of the HER2 testing, then you have to put it as, if it is a core biopsy, you will repeat it on a resection. If it is on a resection, you can try repeating on another block and see. And if still it is positive, then you have to put it with a comment that this is an aberrant kind of positivity pattern.
There's another question from anonymous attendee. On assigning ALRED score, if there is heterogeneous staining intensity with a large proportion of showing weak staining, smaller proportion showing strong staining, how would you assign the ALRED score?
Yeah, so that is why I showed some number of patterns of staining that you can get. So, if you say that there is, say, 70% cells showing moderate staining, so it would become like 5 plus 2, 7. And versus if you say that there are 30%, sorry, 50% cells showing strong staining, that also comes to 7 by 8. So actually, ALRED score has the heterogeneity inbuilt into it. You might have some amount of heterogeneity of expression. It is kind of inbuilt into the scoring. You will not be wrong by more than 1 point if you decide to go by one or the other. Yeah. Most of the time, your points will come out to be the same if you assess the strong, smaller proportion or a larger proportion with moderate.
And another question: can GATA3 be negative, triple negative cancers?
Yes. That is well known. That GATA3 can be negative. If it is positive, weakly positive, it helps. But if it is negative, we usually use these days TRPS1 antibody to confirm breast origin. As I said, provided the gynecological malignancies have been ruled out.
Yeah. Another question from Smita, madam. Any comment on basolateral staining in micropapillary CA, and how do you report it? Any comment?
Yes. So this is one of the aberrant patterns that I mentioned in the. This is one of the. Patterns I mentioned, basolateral staining, we reported as EQ by fish.
And one more question: how do you keep controls for HER2 in the routine testing of cases? Do you use composite control daily? I think
we have, because we are a high volume center, we have our IHC machines running in 3 batches 24/7 throughout the day. So we have one control, composite control with every batch. We can afford it because we have huge number of volumes, and we need to have, because even if one batch goes wrong, it is, the whole testing will go haywire. So yes, we do have a composite control that is run in every batch. At least one of the sections of composite control is run with the whole batch.
I think that finishes the questions. I request any more.
There are 2 more questions.
Oh, 2 more questions.
One, is it mandatory to give ALRED score? Can't we just say the percentage and intensity?
No, it is not mandatory. It is a institutional preference. You can even ASCO-CAP only recommends giving positive and negative with more than 1% being called positive. It is just a semi-quantitative method to give an idea of what is the strength of positivity. So giving an idea of how well it might respond to the endocrine therapy. And that is where this 1 to 10% low ER came about after giving this kind of scoring for a long time, and people realize that it is more like triple negative. So that way, even if you give the intensity and percentage, that is also enough. It is not a mandatory criteria as per ASCO-CAP, as long as you have mentioned, yes, the intensity and percentage.
Madam, one more question. Dr. Anita has asked,
Yes.
in an IHC HER2 with heterogeneous staining showing only focal 3+ positivity, that is more than 10%, and the remaining area being 1+, which field area is chosen for FISH signal counting?
So if it is a core biopsy, that is not an issue. We take the whole core. If it is a resection, we generally try to put our FISH on that. But in that particular case, we put it on the whole section. We do not select the area in that particular case, because cluster heterogeneity or intermix heterogeneity, we will only be able to make out when we have the whole section. So this is one particular case where we do not trim the block and we take the whole section.
Madam, Vijayalakshmi Madam has raised the hand. Dr. Vijayalakshmi. Madam. So please unmute her.
Is the question visible? I cannot see anything.
No, she's raised her hand.
She's raised her hand.
Madam Vijayalakshmi Madam, are you there?
Yes, Madam is there, but I think she can't.
Can I ask a couple of questions to Dr. Ayushi then?
Of course.
Yeah, that was very nice and very elaborate, very informative talk. So just questions like, actually the question is to Dr. Sanudev. So if we give us ER low positive, how will you treat?
ER low positive and provided HER2 is negative, right?
Yeah.
I treat it like a triple negative. Like if you say that ER low, like maybe less than 1 to 10% range, I treat like a triple negative. But on the adjuvant setting, I'll give hormones, right? Like a T3 disease, you say that ER is around 8%, PR is negative, HER2 is negative, K, whatever. I may start on neoadjuvant treatment, proceed with surgery, then adjuvant.
It does matter to you that we call it, we give ER low positive.
Yeah, yes. Clinically, yes.
Okay, right. The next question is to Dr. Aishi. When do you get this false positive ER?
False positive ERs we have seen, as our detection methods are getting better. All these guidelines and criteria, they were developed at a time when the IHC was still in an infancy. Our detection automation was not there. A lot of work was being done manually. Now, as we have shifted to automation, our techniques have become very sensitive. So, sometimes this, even in metaplastic, as I mentioned, we might once in a while, or even triple negative tumor, otherwise we might see little bit of ER positive, feel that the morphology is not matching. You can always advise to repeat the ER testing in the resection. If in the core biopsy you feel, because also it might be in overfixed tissues also, you might sometimes see a little bit of false positivity. So in such cases where again it is not matching the histology, we advise to repeat it in the resection. That we can give the score as we are getting it, but we advise that it is advisable in this particular case to repeat it in the resection. In many such cases, we find out that in the resection, it is actually ER negative.
Okay.
Or most of the time, even if it is positive, it is in that low positive category.
Right. And the next, my question is regarding controls for HER2. You said you put the entire spectrum of controls right from 0 to 3+, isn't it? In every, along with every test.
Every batch, not every test. Every batch.
Yeah, every batch. Okay, so how do we exactly get these controls? Meaning, only in hydrology centers you know exactly what is 0, 1+, 2+. 3+ is okay, fine for us. What about 0 and 1+? So we'll need help to get these controls right, isn't it?
Yeah, so that is what even till last year we were also using this thing. We were using 0/1+, 0 dead negative kind of 0, and then we were using 2+ and 3+. But now we have also shifted by inter-observer concordance, that you see a number of slides and you say that no, this is definitely 1+, and everybody agrees that this is the concordance that we have, this is 1+. And some of the cases we have also had fish testing done, so we definitely know it is not amplified. So in though we have with an inter-observer concordance, what was decided with a good properly fixed tissue, we are sure that this is not a 2+ staining and is not a 0 staining, and there is concordance on that particular area, that particular block we choose for taking as control for making our composite control.
Okay, so for all low HER2, fish is required, isn't it?
So for 1+, no, it is only for the 2+, where we as it is are going to do fish, and if it turns out to be non-amplified, it is called HER2 low as per the current definition. That if it is IHC 1+, or it is HER2 2+, but it turns out to be non-amplified on fish. That is the reason ASCO-CAP is not recommending to put HER2 low in the IHC report, because at that time we do not know what the fish result is going to be for the HER2 2+ cases.
Okay, so which means that if you put a HER2 1+, it still has to go for fish.
No, not for fish. That is actually a HER2 low. As per the current definition, 1+ is HER2 low, but 2+ you cannot call HER2 low, because at that time you do not know the fish. If it turns out to be non-amplified, it is by default HER2 low.
Okay. So as of now, 1+ does not need fish.
No. Fish is only, the criteria for fish testing have not changed. It is still the standard 2+.
And the last question, like you have a suspicion of a carcinoma of unknown primary, is suspecting breast. So what are the markers that you put in?
So if it is a carcinoma unknown primary, first of all, depends on the location. If it is an axillary or what location we are looking at. If they are clinically suspecting breast, is there a breast mass? If there is a blanket, this thing we do not know at all, it's a supraclavicular lymph node or something, or a cervical lymph node, it could be anywhere in the body. First, in the first panel of markers, we do put majority of the, depending on the age and sex, we will put more of nuclear markers. This thing we will put a GATA3, we will put of course TTF1 and CDX2, and in addition 720, and accordingly we will decide on the next panel of, and Paxate, and accordingly we will decide the next panel of markers. The caveat being that triple negative can be GATA3 negative. So if we are suspecting morphologically that it could be a triple negative also, we will put a TRPS1 in addition.
So do you use mammaglobin and GCDFP15 along with GATA3?
No. Our experience, as you very well know, mammaglobin and GCDFP are so non-specifically positive in so many things.
So you rely on GATA3.
That is why I said specifically we rely more on the nuclear markers rather than the cytoplasmic ones.
And if you have a doubt of GATA3 is negative, you put in TRPS1.
Yes.
Okay, thank you.
Vijayalakshmi madam?
Yeah, can you hear me now?
Yes, madam.
Okay. Good evening, everybody. Aishi, your presentation was excellent.
Thank you.
And there are one or two questions I have doubts, practical questions. Now, to continue with what Nina had asked, actually, we are using an external control for every specimen we run on HER2 and ERPR. Now, if you're asking us to take 3 separate control per batch, then do we need to use a control with every section? Hello?
So we make a composite control where, yeah, am I audible?
Yeah, you're audible, Aishika, but I can't see you. That's different. Okay. Yeah, right. Go ahead.
Yeah, so actually we make a composite control that we have ER positive, ER negative control in the same block.
No,
And
I'm talking
similarly,
about
we have a
HER2. Aishi, I'm talking about HER2 you are referring to.
HER2 also we have a
Yeah.
composite control in which we have put tissues of the known positivity, cores of the known positivity in the same block. So
Okay.
once we have made that particular block, it can be used on one side of the slide. It is not a very big block. They are the cores are maximum, 5 mm, not more than
Okay.
that. So we have those cores. We have a composite block in which the tissues of known positivity are all embedded together, and that one block can be used as a control for each batch.
Each
Not
batch
for
means
every
what?
case, not for every test.
No, each batch means, what about the other cases? For individual cases, you don't need to use a control?
No, it is not for
No.
each case. It is for each batch
No,
because that particular batch has run properly. We
Okay.
test for that, where the batch is run properly.
Okay. Now, second question.
And for the each particular case, 1 second, member, for every particular case, we rely on the internal control. That is why I said that it is important to train the residents to take the tumor section with the adjoining tissue. So each case individually has, or if you have multiple blocks, try to choose the block in which there is some amount of normal breast along with the tumor, so that besides the external control, which is put in one of the slides of the batch, in every case, you have at least some amount of internal control. So you know it has worked on that particular slide as well.
That includes HER2 as well?
Yes. No, so of course not HER2, ma'am. That is
That's what
just
I'm
for
asking. I'm
ERPR.
talking about HER2 right now.
Sorry,
Internal
no.
control of
So
ER.
actually HER2, no, this is only batch control we put for HER2. HER2 does not, of course, have internal control. But if in that particular case, the ERPR control has worked on that particular corresponding slide of ERPR, that means at least the tissue is antigenic.
Yeah.
The tissue is working properly. So if the HER2 is, even though there is no internal control, the IHC has worked in that particular tissue. So if the ERPR internal control are negative, then we are not sure even if the HER2 has worked properly or not.
Okay. Now, another question is that, you mentioned about additional markers in TNBC, right? So what are your recommendations? Should we do AR and VDL1, or ask a clinician or discuss with them that it's necessary?
Yeah, so we do it only on clinical request in a particular patient where they need it for giving, deciding, because when the patient is metastatic or advanced setting, I think Dr. Sanudev will agree with me that when there is the routine therapy options have been exhausted and the patient has presented now with advanced disease, then they take either a fresh tissue or whatever was the most recent tissue that was evaluated. On that, they request us for AR and PDL1. There are basically many times, markers of desperation that if, at this point, if the tumor we find it is positive for PDL1 or AR, then they can offer some targeted therapy to the patient.
Okay. Now, you mentioned just now that we don't have to mention HER2 low or ultra low. Could you just explain what is this ultra low? I just lost you somewhere, actually. Could you just explain what this HER2 ultra low is?
Actually, this is just a possible potential terminology. It is not yet come into use. It is possibly potentially might be useful because there is a trial going on which is testing whether IHC expression between 0 and 1, very faint here and there, some staining, can that also be targeted by this new drug TDX available? So there is a trial going on that is testing. If that trial results are good, then we might have introduction of this terminology as well. As of now, that is not an acceptable terminology. It is just a potential terminology. So I was just introducing this terminology because once the trial results are out, you never know, it might come into being for the pathologist that we have to report on this as well.
Yeah. So one more question I want, but you mentioned about dish, right? Now, can you just tell me in brief that suppose I want to introduce it in my lab? Now, how do we go about validating? What is your protocol for validation? Could you just tell me? You said no, we have to, of course, we have to validate the test. Yeah.
So we have validated against known fish results, and in keeping, so when we validated, we used IHC negative, equivocal as well as positive cases, and the equivocal cases, all of which were confirmed by fish. So in those particular cases, we validated our results that the concordance between the fish and the D dish for negatives, for equivocals as well as for the positives.
How many cases do you think we need to work on to say that, okay, we have validated?
Yeah, as per your NABL guidelines, I'm not sure if there is NABL guidelines for evaluation of D dish as of now. We would recommend at least 20 each to be sure that there is no fault. Yeah, we would recommend. And you might have, definitely you would be having cases in which you have done fish in a large number of cases. So if you have fish results available, so those known cases you can take to validate D dish. But remember that D dish does not work very well on old tissue.
Okay.
It does not work. Fish works like 2 years, 3 years older tissue. The D dish does not work very well. So it has to be a little bit more recent tissues, like last 1 year.
Within 1 year? You mean to say that? Within 1 year, can I take the blocks?
Yes.
That's accepted. Yes. Okay. Thank you so much. Thank you so much.
Any other questions?
Yes, madam. There are few questions. So, can I?
Yeah, we can make it fast.
Okay. So, Soxten in metaplastic carcinoma, your experience, how useful it is?
So, Soxten is also a marker of, it comes in a large number of triple negative. It need not be a metaplastic carcinoma. Triple negative run-of-the-mill NOS can also show Soxten positivity. So, we do not use it as the only marker for calling it metaplastic. In conjunction with morphology, yes, but it can come in a number of triple negatives also.
Okay, another question for HER2 2+ control, which tissue you use? Is it HER2 amplified case by fish?
Oh, that is a very good question. Actually, we have not taken a HER2 2+ control in keeping with the known fish result. It is based on the IHC and typical pattern of IHC, which inter-observer concordance is there, that everybody agrees that this is a 2+ case.
Okay, how to report ER with positivity in the range of 1 to 10%? As low positive or positive?
Low positive with the comment that is recommended by ASCO-CAP.
What is the role of AI in calculating IHC grading?
In grading?
Just the question is only that. Which IHC not mentioned?
So the Vigiofarm software that we used for AI calculation of the biomarker testing, it gives us the proportion intensity as well as all right score. Same for HER2, it gives the result as -1+, 2+, and 3+. So whatever the current method of reporting, that has been inbuilt into the algorithm to report that same way.
Okay, questions are over.
Actually, I would have one last request to people like you in working at TMH. Is it possible to circulate controls for HER2, like for people like us?
Madam, I will also have to ask. This is beyond my, over my head. I will also have to ask. Maybe Dr. Asabri, if she's around, she can comment.
Yeah, because actually you're talking of tissue microarrays. your controls are actually tissue microarray, isn't it? Going with one batch.
We are using, we are not microarray. Actually, we are using larger tissue bits, somewhere 0.5 centimeter in size, and that is not a core. Actually, it is a square bit of tissue of 0.5 centimeter size on all sides. So it is like it is cut from a known block of resection. It is not a core.
So you cut those blocks from, you cut those small bits of tissue and then make it a control. Is it done like that?
Yes.
Oh, okay.
So,
Yeah,
can I say something?
Yes, madam.
Yes, madam.
Yeah. So, excellent talk, Aishin. I must say, even the panelists and participants for such a good interactive session. So, just about these circulating ISC controls, actually, that could be difficult in such a way that the ISCs will be standardized in our lab. So, every lab has to have controls which are derived from the ISC that is standardized in their lab. So, the best way is once you get your enough number of cases, try to identify, keep them aside. You don't have to use the entire block, but if you know particular cases, suppose HER2 1+ or 2+ on biopsy, if you have that resection specimen, try to get extra sections from the tumor. And for initially, you may have to spend some money, but have to check the IC again on that block. So I know when you start it, it's going to be difficult. But once you have established the IC, just identify the cases that have been diagnosed in your laboratory with the methods that you are using. Having said that, I don't think any lab is circulating known ISC control because the problem is going to be these are predictive markers, and whatever is standardized in one lab may not be always good for other lab. Best is to participate in ECAS program. So make sure that we are in the same line.
Yeah, that's being done. Yeah. Okay. Thank you very much, madam. So I think we'll wind up, Shiny.
Yes, ma'am.
Yeah, sorry, I took a long time, but I thought there are a lot of updates I needed to get across in a short time.
That's a very important topic because it's very common. All of us are doing it. It's very useful for all of us. Thank you very much, Dr. Ayushi, for that excellent and elaborate and very informative session on biomarker testing in carcinoma breast. It was very useful for all of us. And thank you, Dr. Sanudev, for your inputs on the clinical aspects of the implications of what we are giving you. And thank you all participants for your active discussion and your questions. Thank you very much. And so see you all. And next week we have the last but one webinar, and that will be on updates on the treatment of carcinoma breast. And just a reminder that we'll have a quiz on all these webinars, which will be conducted at the chapter meeting. So wish you all the best, and thank you very much once again.
Good night, everybody.
Good night, and thank you so much.
Thank you, madam. Good night. Bye.